Welcome everyone to this roundtable discussion tonight, co-sponsored by Physicians for National Health Program and National Single Payer. And tonight we'll be talking about the REACH, ACO REACH program, which is a new program developed by CIMI that we will discuss in more detail that is actually a serious threat to Medicare as we know now. Currently, traditional Medicare allows you to see your physician that you choose, and you can go to any hospital that you like in the country. It's simple, it's efficient. You see the doctor and they send a bill to Medicare, they get paid. It's an efficient, low administrative way to provide and pay for healthcare in this country. But now with the ACO REACH program, they want to change this, and they want to insert for-profit entities such as continue with private insurance companies as they are with Medicare Advantage, and also add even more private equity and venture capitalists in the mix, which will end up diverting funds from paying for healthcare to profits for these investors. And while doing this, they'll be extracting billions of dollars from the Medicare Trust Fund, threatening the solvency of the trust fund by 2026, which is not very far away. And all the while, they continue to say that they will address our current racial and health inequities while saving money, when in reality, this proposed taking over traditional Medicare will ultimately only help those involved who want to make a profit. And because of this profit-driven mission, traditional Medicare may not be here to help those of us who will rely on it to keep us healthy later or to help us when we become ill. So I want to introduce our panel to you tonight before we get started. But I will start out with Dr. Linda Murray, who is on the screen there, you can see. But Dr. Linda Murray earned her medical degree and MPH from the University of Illinois in Chicago. Her career includes positions at the Cook County Hospital in Chicago, the Manitoba Federation of Labor in Winnipeg, Canada, Meharry College, and the Chicago Department of Health. She was also the Chief Medical Officer of the Primary Care and Community Health Network of Chicago. Dr. Murray is the former president of the American Public Health Association, where she advocated for the guaranteed right to health care for everyone and argued that healthcare requires peace and that equity and social justice demands a whole and sustainable planet. I now like to introduce Dr. Abdul El-Sayed, who is a physician and the former health director of the city of Detroit. He received his medical degree from Columbia University, and he has a doctorate in public health from the University of Oxford, where he was a Rhodes Scholar there. He was an advisor on the 2020 Democratic platform as a Health Unity Task Force appointee. He holds a I said that already. He is a co-author of a wonderful, fantastic book that I encourage all to read, along with Dr. Micah Johnson, called Medicare for All, A Citizen's Guide. And he is also the host of the podcast, America Dissected, on Crooked Media. And our final panelist is Dr. Claire Cohen. She is a Black child, adolescent, and child psychiatrist who has been practicing in Pittsburgh since 1984. She attended Hahnemann Medical College, now called Drexel Medical University Medical School, and completed her general psychiatric residency at the University of Chicago, followed by a child and adolescent fellowship at the University of Pittsburgh at Pittsburgh's Western Psychiatric Institute. Dr. Cohen has worked in a variety of clinical settings, including community mental health clinics, hospitals, school-based settings, and currently at an inpatient hospital setting. She is a leader in PNHP, in the organization National Single Payer, and with the Western Pennsylvania Coalition for Single Payer Healthcare. So join me in welcoming our panelists tonight as we engage in a which should be a very rousing and interesting conversation on direct contract entities. And I'd like to start out with you, Dr. Cohen, on, can you explain what are the direct contract entities that they've now changed the name to ACO/REACH? And what is it that they're trying to do here?
So direct contracting entities, the direct contracting program was a program that was first cooked up under the Trump administration. And the whole idea was people had noticed that Medicare Advantage plans were actually making a pretty penny. Medicare Advantage plans differ from traditional Medicare in that there's a middleman inserted between the Medicare trust fund and the provider and patient. Okay, so in traditional Medicare, just to make sure people are clear, you go to the doctor treats you, and then the doctor bills the Medicare trust fund. It's basically is what happens, and then gets paid. In Medicare Advantage, which is a soft, sneaky privatization, there's a middleman, in this case, insurance companies. They get the money from the Medicare trust fund, and then they decide how much to pay the providers who treat you. DCEs were taking it a step further. DCEs, a lot of private equity firms and venture capitalists looked at the money that Medicare Advantage was making. They wanted to get in on the goods too. They noticed that a little over half of people in Medicare were in traditional Medicare. They figured if they could get those people into the private market, that a lot of money could be made. So basically, what it's all about is inserting profit-seeking middlemen between you and your doctor and the monies from Medicare, and so that they can take some of that money for their profit. And that's the basic idea. If you got that, you've got it. Okay. So there's a variety of ways in which this is done. In which this is done. One is, first of all, Medicare gives each plan, whether it's a DCE or a Medicare Advantage or now ACO REACH, a set amount of money every year, and that's called capitation. That amount of money varies to some degree depending on the illness you have and how severe your illness is supposed to be. And when they're given that money, these entities understand that they don't have to use all of it for your care. If they were Medicare Advantage, they had to use up to 85% at least. They had to use 85% at least. They could keep 15% for whatever they felt they needed. DCEs are allowed to keep up to 40%, and they have to spend at least 60% on patient care. So it doesn't mean they're going to always spend 40% on whatever they want, but they can keep that much. And the whole idea is they make a profit, and someone thinks that by their making a profit, you'll get better care. Although 30, 40 years worth of studies looking at Medicare Advantage has shown that just the opposite happens, that this kind of way of practicing, of financing medicine, increase costs and worsens the quality of care. So back in the waning part of the Trump administration, this DCE program was conceived and started. Trump did not stop it. And it has continued to go. The problems that we have to worry about is that it's basically siphoning off the public's money to pay investors who just want to get rich, who have no interest in care. Last year, $12 billion was wasted. More than $12 billion was wasted on these Medicare Advantage. We can imagine when these programs get really going, that even more money will be wasted. That was $12 billion spent more than for patients who are in traditional Medicare. The Inspector General's office has shown that over the past 12 years, about $140 billion have been wasted, not used for the treatment of patient care. These programs, now to go specifically to DCEs, how they differ from Medicare Advantage. Medicare Advantage patients choose, seniors and other and disabled beneficiaries choose to enroll. These programs, patients do not choose to enroll. They're aligned in by the doctors that they follow without real knowledge or consent, okay? On top of that, it's very difficult to get out of them. The only way you can get out once you're in one is you have to quit your doctor, which could be a problem if you really like your doctor or if you live in a place where there's a shortage of doctors. So that's the biggest problem. The other problem is that they've been doing, all of these programs have been doing something called upcoding. And upcoding is when they are given money for more money if you're ill, based on your illnesses. And they've mastered how they can make you look sicker so they can get more money to make more money, to make more profit. So the biggest difference, I'm going to just wrap up by just saying, well, what's the difference between ACO REACH? We've been fighting to stop the DCEs. And the result has been that CMS, that Medicare, has decided to rebrand DCEs and call them ACO REACH. So what's the big difference between ACO REACH and DCEs? Not much. First, they're still keeping profit for middlemen. They're still allowing upcoding. They're still providing incentives to restrict treatment. There's still that up to 40% is profit and overhead. It's still potential to bankrupt Medicare even more. Still auto-enrolling seniors. Still allowing private equity and venture capitalists who have no interest in your care to become the middlemen and profit from public dollars. And then there's problems that make the program even worse. They're supposed to be about equity, and I can maybe talk about that later, but it's very clear that the way the program is set up is the potential to use people of color to help them make more profit rather than to really benefit people of color and provide better care. I'm going to stop there because I'm getting sick, and I'm sure people will have questions, and I can explain even more the problem with this ACO REACH and DCEs.
Well, I want to give our other panelists an opportunity to make a comment if you have any, to expand more or mention something about the ACO REACH program that we have. One of the things that has been made clear is that the insertion of for-profit companies within our public healthcare systems has been worsening over the years, over the decades, ever since when the Affordable Care Act was first instated. It was, I think at the time, the largest transfer of public funds into the healthcare system at the time. And now it's become what is considered routine, and it clearly is interfering with the delivery of care. It's interfering with the ability to control the costs of that care, and it has not done nothing really to address the inequities that we see.
So I think this, first of all, I'm glad to be in the webinar with my fellow panelists. I think it helps if we basically just step back and simplify things. So Dr. Cohen, I think, outlined beautifully the problems. And it's really easy, certainly me as a public health person, it's really easy to get sort of furious at the details, the upcoding and that are in this ridiculous plan. But let me just back up and make it really simple. The first clue, I would argue, that you should have a hint that something is wrong is it was started during the Trump administration, but not just to rain on Trump. This is a philosophical position of parts of our country. I don't think most people in our country think like this. And so let me just say it clearly. There is this belief, that's all it is a belief, almost a religion, that if you do things by the marketplace, if you let the invisible hand of the market work, you'll automatically get better systems. My political scientist friends call that neoliberalism. You know, I'm just a doctor, so let me just, so why would we think that by trying to allow some people to make even more profits that are already made off of people's health and illness, that somehow gives a healthy population? I think the key thing to remember here is most Americans, most people on this call and most people in the country, they want the healthcare system to make people healthy, to keep people healthy. You know, their idea of a good outcome is more people that are healthy and more communities that are healthy. That's very different than being financially efficient or maximizing profits, which is what, unfortunately, these two programs, the DCE and then the rebranding, that's all it is, REACH program. We'll talk more about health equity later. So I think if we just ask basic, simple questions, do you really think that somebody who doesn't know anything about healthcare can somehow restrict what care you get, and that will automatically make you healthier? We know it automatically makes more profit. So I think that's really the question. What's the purpose of our medical care system? And what do we need, which we'll talk about later on, to really be healthy as individuals and, more importantly, as families and communities?
That was excellent. And the only piece that I'll add to a very good set of explanations is that we're operating in this space which says implicitly that the fundamental reason why healthcare costs are so high is because people use too much healthcare. Because the way that doctors make money in this system is, in effect, is by taking that money, that capitation, and then not spending it on healthcare. And they get to keep the rest and put it in their pockets. And so the incentive here is, in effect, to say, all right, you're going to keep your patient healthy, and therefore you get to keep money. But the problem with that thinking is that it assumes that doctors are the ones who are keeping patients healthy to begin with, that there's a lot that a primary care doctor can do beyond the community in which someone lives, which then opens the door to a whole bunch of cherry picking problems, right? These are the kind of patients that a doctor in a DCE system is going to want to take care of, are the ones for whom privilege and context are keeping them healthy in the first place. But then the second problem is the notion that somehow the reason healthcare is so expensive is because people are using too much healthcare. It's the same issue underneath the idea of quote unquote cost sharing, right? Deductibles and copays, is that, well, you have to have people have skin in the game, as if their literal skin is not in the game when they're getting healthcare, in order to reduce their healthcare usage. The problem, though, is that it does nothing about the per unit cost of healthcare, the pricing of healthcare, which of course is the central reason why American healthcare is so expensive, because it bakes in the overhead of the insurance companies, of the hospitals and the clinics. And so it is wrongheaded from the jump. And then the last point I want to make about this is just to reiterate this notion. This is a backdoor privatization of Medicare. This is an attempt, right? If Medicare Advantage is about seniors choosing to privatize their Medicare dollars without actually knowing that they're privatizing their Medicare dollars, DCE is about doctors backdoor privatizing the Medicare dollars. And this is a unique affront to Medicare as we know it. And the sad truth is that our colleagues, our physician colleagues, are the principal target of this effort.
Thanks. Oh, go ahead.
I'd just like to add to what the two of you said, is that this is the health care, insurance, pharmaceutical industry is very calculated and well aware of what they're doing. I've been reading some recent articles. They're hoping that this model, that what they're doing to Medicare, can expand to all of healthcare. I was reading an article in which they were saying this can be a way to make sure we never have single payer healthcare or a national healthcare system. And one of the articles in JAMA was calling their approach Medicare Advantage for all.
Yes, clearly the for-profit industry has been eyeing this for a long time. And one of the things too, and I really appreciate everyone's comments here, because it's so important to try to put this all into one big picture. But one of the things that, prompted all of this, the argument, was that the biggest problem was fee for service, that it was greedy doctors who were ordering and doing all this stuff to make more money. But now it's the greedy insurance companies, it's the greedy private equity firms, it's all of these other entities that are now the greedy ones. However, they are demonizing physicians as being the greedy ones and the cause of this problem in the first place, which clearly is not true. The studies show that when you compare us to other countries in Europe, we underuse care. We don't see the doctors as often. We don't get as much treatment. We often can't afford the medicines that we need to fix whatever it is that's broken. So underuse is part of how this system functions. And that was done on purpose. It wasn't just something that just happened to happen. That was part of the structure on which our healthcare system is created. And maybe we can go further with this, Dr. El-Sayed, when we talk about alternative payment methods, and that there's been a lot of talk about value-based care. And that's now the big buzzword, let's get away from fee for service, because that just concentrated on volume and didn't address value, so they say, or what they want to argue about. But what about value-based care? That's the latest term that they're using, and they maintain that using value-based care would save money, it would improve health outcomes, and it would also achieve health equity. So can you describe to us what value-based care is? And do you really believe that it can do all that? Can it save money, and can it help address the inequities that we see?
Yeah, I really appreciate the question, Susan. And look, in principle, the idea of value-based care is to say, listen, rather than rewarding the volume of care that we do, right? You produce one unit of healthcare, you get reimbursed for a particular amount of money for that unit of healthcare. Rather than doing it that way, we are going to pay you for the outcomes of your care, whether that is in a localized setting to say, listen, your surgical outcomes, if you're a surgeon, or that is the overall level of health of the patient census that you keep, right? There are different ways of thinking about this. But the idea of paying for the quality of care, or the health, which is what people value, is not a bad idea. The problem with it is that it does not address the structural failures inside of our healthcare system. The fact that our healthcare system is predicated on private employers paying private healthcare insurance corporations to reimburse for care provided by private, increasingly corporate hospital entities. And that fundamental problem is really where the structural cost of our healthcare system sits. So you could imagine a world where you included value-based care models inside a Medicare for all system. But the point here is that, it's like, if you have a mosquito that's about to bite you and you have a lion that's about to attack you, yes, you could focus on the mosquito, but you better run from the lion. And the unfortunate thing is that people who posit that value-based care is going to solve our problems are busy swatting the mosquito rather than running from the lion. And I just think it's important for us to keep scale in mind when we think about these different aspects. The last point I'll make about value-based care is this: it is extremely gameable. If you look at the number one determinant of the health and well-being of a particular patient, whether they are post-surgical or they're just living their lives, it's the place that they live and the circumstances in which they live, whether or not they can afford a good roof over their heads, they can eat healthy food, they can consistently get access to exercise. And so you can imagine a circumstance where if the goal here is to address equity, you actually create a counter incentive when you think about a value-based reimbursement, because by definition, those patients that tend to perform best, as we all know, tend to be the patients whose outcomes were better predicted by the circumstances in which they live. And so what happens here is that physicians now face a disincentive to caring for the lowest income, the most marginalized patients who need their care the most. And so it is important, right? It's possible to build value-based systems that really do incentivize care for the most marginalized and the most underserved, but it's not an obvious thing, and it has to be designed that way. And I worry, right, that when you think about who's designing these systems, they're not going to necessarily be designed to maximize the well-being of the most marginalized folks and tackle health inequities that we have so pervasively in our system. They're going to be designed around how to maximize the profit margin for a particular hospital or clinic. And so, so the way I want folks to understand this is that they're fine. They're not going to take on the biggest issues in our healthcare system unless and until we situate them within a broader paradigm of taking the financial incentives out of every specific interaction or financial transaction in the healthcare system. And we have to make sure that we're designing them to specifically to incentivize physicians to tackle inequities. Otherwise, they can be easily gamed, and physician practices can cherry pick patients so that that their patients generally have the best outcomes as a circumstance not of their care, but of their demographic characteristics going into their care.
Yeah, I appreciate. I'm listening to what you're saying, Dr. Sayed, and I appreciate it, and I'm hoping that people watching this are getting what you're saying. So I want to use a real down-to-earth example of what you're talking about, just to make sure people are getting it. And because I'm a child psychiatrist, I'm going to use a child psychiatrist, just a real simple example. So I deal with a lot of very sick children. And one of the things that happens is the color of pills. This sounds simple and silly. So and this actually just recently happened, but it's not happened once, but it just happened last week. So I had a patient who was psychotic, first-time psychosis, teenager. And I started her on medication. And the medication, this particular medicine happens to have different colors for different doses, for its different doses. And as you know, nowadays, a lot of insurance companies won't authorize you given more than 30 pills in a per month in a prescription. But this patient had an issue. She loved the orange color. She hated the blue color. And it sounds like something stupid, okay? But the problem was she needed to go up in dose. And the blue color was about twice the dose. The orange was 1 milligram, the blue was 2. So before all this value-based care and all this privatization, it would have been real easy, because I used to do this in the past, to say, okay, well, you just get 2 orange pills to get the dose that I need you to get, okay? But now I have to fight an insurance company, which is going to tell me, which telling me you have to give 1 blue pill. But what does that mean for the patient? That means she doesn't take her medicine, she doesn't get treated, because the value for the insurance company is saving money on the number of pills. But my value is seeing that my patient takes her medicine so her psychosis can clear. And now I'm stuck. So I don't know if that kind of in a concrete way makes what you're saying, helps people understand what you're saying about how this value-based system interferes with care. And I can give many other examples that are more complicated than that. But I thought that maybe if you think that's a good example of how this interferes with patient care.
I think it's a really good example. I think one of the pieces that your example highlights is the role that that increasingly in these value-based systems, you're going to have algorithms that are pre-programmed that are making these recommendations because the blue pill in your situation is cheaper than the two alternative pills. And so that's going to be the recommendation that gets made. And if you don't follow that recommendation, then you're not practicing value-based care. And I think all physicians ought to be really, really worried about the implications of having pre-programmed algorithms, many of which are not transparent. Frankly, a lot of them get actually patented, and so they end up being owned by some corporation that can buy and sell them or trade them, that then interfere with your ability to care for your patient as an individual. And so that's a really good example of some of the consequences in terms of patient care that folks will face. I really appreciate you sharing that.
The other thing I would comment on value-based care is it's the same, similar to what I said earlier. We have to ask whose value. When you say value-based care, there's a judgment involved in there. What are you valuing? Are you valuing saving those dollars with the blue pill so that I have more profits at the end of the year? Or are you valuing taking care of this adolescent? The other thing I would say is that in my mind, when they use words, and these are really just, these are bullshit words. I mean, they don't mean anything. So we shouldn't fool ourselves. If we really wanted to decrease waste in the medical care system, there are things we know work from around the world. We could, for example, have all the benefits be the same in the country. Right now, depending on what company you have, what flavor of health insurance you have, and even with Medicare, what Medicare Advantage things you have, and I'm now Medicare age, and so I must get 5 calls a week easily from these Medicare Advantage groups trying to trick me into joining one of them. And what they're selling is, oh, maybe you can go to the health club, or maybe you could, the benefits that people should get should be exactly the same. And they should be benefits that help people stay healthy. And if that means a gym club membership, if you have a club around, I mean, I'm not against that, but it should be the same for everybody. It means if you need transportation to get to your medical care visits, everyone should have that transportation. So that immediately, that standardization would save some money. There are other things we could do. We could outlaw profits from primary care. We could do that. We could control the costs of pharmaceutical drugs, which many, many other rich capitalist countries do. So there are things that we could do to deal with inefficiencies in our medical care system, economic inefficiencies, that we choose not to do because we have that philosophical commitment that the market is the best arbiter of all things. And so when we think about value-based care, I would hope all my care is value-based, no matter where it's going. I hope I'm getting good value for the medical care that I receive.
Those are excellent comments, and thank you so much for bringing all that up. And I think one of the underlying themes with value-based care too is that it really belittles the role of the physician. I mean, we could see, 10 heart failure patients, they could all be on the same medications, but they're treated differently. They're not robots and exactly the same. And it's the same with treating children, and you have to change the color of the pill. So as the physician, you have to know when you have to adjust that. And that is no longer appreciated. And I don't know if it's, whether we call it burnout, or is it really, this isn't what I went to medical school to do. I didn't go to medical school to be on the phone to talk to someone who can spell healthcare, and that's the end of their knowledge, who's second guessing my decisions. And I've often asked, is that illegal? I mean, I have to pay for my license so I can make the decisions that I was trained to do. So it's very complicated, but it's eliminating slowly our role and second guessing our judgments. And I do want to make a comment. I think I may have forgotten to mention too, that this whole webinar here, roundtable discussion, is co-sponsored by PNHP, Physicians for National Health Program, and National Single Payer, which is a separate organization that is dedicated to trying to get single payer for this country. So yeah, this value-based care, and the other thing is that it makes it difficult to treat difficult patients because they often cannot get you to the value that the insurance companies want you to have because of the social determinants of health, other issues with them. And so physicians get penalized for trying to take care of those patients when they can't get the quality metrics that they want. So it's actually worsening inequities rather than improving inequities by having it tied to the finances of the physician. But I don't know if anybody had any more comments about this that they wanted to say, or.
I mean, one last point that just we all have to appreciate here is that all of this stuff tends to happen within a system that is entirely dictated by the needs and profit motives of corporations. And you know, it's interesting. Early on in my career, I used to think that the reason that healthcare, and I was very naive at this point, the reason healthcare was so important or so expensive was because physicians were the ones that were profiteering off of the system. And all of this, you know, you think about this, all of these profit motives depend upon a system that has excised physicians out of the nature of healthcare provision in the first place, right? So doctors are not central in healthcare any longer. And so all of these little bones that get thrown out, right? They get thrown out in a circumstance when, you know, you look at the nature of physician pay, and more importantly, the nature of physician control over healthcare has been completely excised by large corporations. The median physician in 2018 no longer worked for a physician-owned practice. Increasingly now, your job is to produce RVUs for a large healthcare provider, right? And so this whole system, right, it has sort of choked off doctors, and then said, all right, if you do things our way, we're going to throw you a couple of bones, which means that we're going to algorithmically modify the way that you practice to the point where you are in effect doing or providing less personalized care, and then we're calling it value-based care, as if that's what people actually want in their physicians. You couple that with mergers and acquisitions and the ways that large health systems have fundamentally really eliminated the choice of the system that you can choose to attend. And you have this situation where, you know, the point that you're making, Susan, becomes really quite profound.
Yeah. Another thing that I want to add, it also it severely interferes with the doctor-patient relationship. One of the things I've noticed, there used to be a time where patients loved their doctors. I find more and more people talk about how they hate their doctors. Doctors, you know, a lot of, I try my best to practice humane care. Okay. So I resist spending 10 minutes, which I don't think a psychiatrist can do anything in spending 10 minutes with a patient, or 30-minute eval. And I see a lot of patients that are not following medical advice, that are not taking their medicine, that are not going to their therapy. And I will ask them why. And again, I hear, I don't trust the doctor. I came in, I wanted to talk, I needed time to talk, and he just wanted me in and out. He wants me to take this medicine. I don't know what this is going to. Now, I'm mostly talking about poor and overwhelmingly Black patients when I talk about this, but even some of my white rural poor patients bring this up. He wants me to do this, and I don't know what I can't. I don't know what this is going to do to me. Or you have a mother who's working 2 jobs, and they're asking her to be home to do in-home family therapy with her patient. And then she's considered a bad mother because she won't do it, but she needs to make money. She's got two minimum wage jobs, and she's being called a bad mother because she can't be there to take time off to do inpatient, to do in-home family care. But the people don't look at the life circumstances of patients, and you hear people just really degrading patients and parents in the case of my patients, and how they don't care. And one of the things I've had to point out again and again to colleagues, it's the system is not set up for struggling poor parents. It's not set up to help them provide the care that their children need.
So what do you think should be how physicians can try to help respond to this push to do things or not do things that are not necessarily in our patients' best interest, but in the financial interest of the private equity firm or the private health insurance company that may be owning your group or whatever, because a lot of the problem too is that physicians are now employees. And we are just as expendable, despite the years of training it takes to get to this position. We're just as expendable as someone else who may be answering the phone or doing something that requires nowhere near that amount of education. So
I think this requires physicians to actually try to live up to the oath that we all took. We know most people, when they start medical training, they start for mostly the right reasons. I can't say that that's what happens 10 or 15 or 20 years down the road. And so what does that mean in English? We have to be willing to stand up and take the professional training and knowledge we have and speak out clearly and loudly and put our weight behind things that we know keep people healthy. Not just keep our patients healthy, which is the first requirement, of course, but keep the people around them healthy. Because if my patients are healthy, but they're living in the community with the unemployment rate that's through the roof, or opioids being passed out at the local pharmacy, there's only so much that can happen just because they happen to be my patients. And so that means we as physicians, and we've made progress when this happens. I know certainly for Black physicians, we have to be willing to stand up and say, changing that Voting Rights Act hurts my patients and makes them sick. Closing schools to save money hurts my patients and makes them sick. Look at what's happened. Talk about our young people during the pandemic, the huge increase in mental health stress, just at massive levels. But this stress is here all the time in certain pockets and marginalized groups. So if we're willing to stand up and lend our voices with the communities that we're privileged to work and serve with, then I think we're meeting our professional obligations. That means joining with other health professionals across the spectrum. Physicians are just one group, as we know, and lending our political weight around things that we know makes people healthy. So we know that the earned credit income thing for the kids that happened during the pandemic, that raised millions of kids out of poverty. We know that's good for kids. So stop goofing around and pretending that it's not. So we should be fighting for anything that improves the health of people that live in this country. We know what hurts people, and we know what helps people. And if we have some questions, then I would think as physicians, you have to get to the right diagnosis before you can get to the right treatment. So that means we have to take our time and learn some more about what we call the structural conditions that really determines whether people are healthy or not.
So if we're discussing the DCEs and ACO REACH, and what they're saying is that this can help address inequities. How do we respond to that? Because what we've been saying is that they can't address the inequities. That's not the solution.
I think the first thing for us as physicians, let me be careful here. This is not something most physicians are trained in. So we are really not the experts, generally speaking, in this area, even though it has health connected with it. And so what that means is, first, we have to listen to our health colleagues, public health. Nursing does better at this than we do. Sociologists, historians, we have to listen to people who understand what you need to keep a healthy society. But in any case, what we do know in the area of health equity is that, as I mentioned earlier, it's not just making sure the blood pressures are the same, okay? We have to understand the whole context in which people live and work. And we
Like
have to
living in a food desert.
Exactly. So we have to do that on a population, on a group level, okay? Because we know that these other, it's not just a question. There's often a misunderstanding that if you're because we act as though social determinants of health are somehow character flaws. I'm poor, so therefore, that's not what we're talking about. Social determinants of health are things that we collectively determine in our society. We forget, for example, let me pick one example that's frequently been in the news recently, the horrible increased maternal mortality among Black women, followed very closely thereafter by the horrible maternal mortality rates among Native American women. But what we fail to mention too often in these newspaper articles is that the maternal mortality for white women has been going up in the past several decades, very different than other rich countries in the world. And so when we think about why this might be happening, yes, racism is there, but it's happening because the fabric of our society is being shredded. I think by this philosophy that the best thing we could do is turn everything over to the market and allow people to make as much money as they want. If we think about the response during the pandemic, the collective natural response that happens when there's a tornado or a hurricane or an earthquake or a pandemic, people naturally come together and try to help each other out. And that's what we have to say. That's the value as physicians that we need to promote. We need to say, that's the value we need to stay healthy. Everybody should have an education. Everybody should have a job or an income. No one should be unhoused. No one in this country should be poor. And so if we're willing to speak about that, and if we're willing to address the racism that exists in our country, we're not going to solve health equity until we address that and confront that head on. If we're willing to look at the class differences that exist in this country, why you can't, in the city of Chicago or New York or LA, you can't live on $15 an hour if you're working 40 hours a week. We should stop pretending like that's a fair wage. We need to say people need to be able to go to a job that's safe. They need to have a job with dignity where they're respected. They need to be paid a living wage, not a minimum wage, a living wage. They need to have a system in place so that when they get to the point where they need Medicare, because right now you have to be old to get Medicare. When you get to your senior years, you ought to be able to have a retirement with dignity. You ought to be able to, as Sir Michael Mermott said once, he said, as an old grandparent, you ought to be able to buy your grandkids, however many you got, a birthday present. You know, that's part of being healthy.
And if you are very sick, for example, I have a mother with Alzheimer's, you shouldn't have to spend yourself into poverty to get what you need, to get the resources you need, which is crazy in our country. People, in order to get resources, I mean, my mother, who's 96 years old and barely knows who I am, some days has no idea who I am. You know, every year I get this thing. Where's she getting money from? What resources does she have? I mean, what's the purpose of that? She's been incapacitated for about a half a decade now. Why do we? And I mean, it's a big packet. And I'm looking at my patients that have to fill out the same kind of stuff. I mean, what's the purpose of that? Why do people need to impoverish themselves to get resources and services that they need?
I wanted to just quickly jump back to the previous question that you asked about what doctors can do. You know, for a long time, the AMA has claimed to speak for American physicians, and it is organized. If you look at, you know, what the structure of the AMA was and when it was organized as a guild. And what a guild is it's organization of small businesses. But physicians are no longer small business owners. Physicians are line employees. Instead of making widgets on a line, we make RVUs. And so it is high time, I think, for physicians to organize like workers. And I worry that for the past several years, despite worsening working conditions, particularly in the pandemic, and a dwindling level of reimbursement in terms of care as a function of what an overall hospital makes, you're watching physicians get ployed into choosing not to organize because of the traditional ideals of what being a doctor meant. That this was a high profile, high class profession that earned a certain level of income, and that we wouldn't deign to organize the same way that workers and other services organize. And I think it's time for us to get past that and recognize that we actually do need to organize the ways that unions organize. And the reason that that's so powerful isn't for what it can earn physicians, but for the power that it allows physicians to have in unity against management of hospitals, and also in terms of setting policy across hospitals and clinics. And you think about these kinds of policies and the capacity that a physicians union would have to be able to push back on some of this and to argue that this is actually ultimately not in the best interest of either physicians or our patients. But we don't have that kind of unity right now because in so many ways we've been tricked into thinking that somehow our profession is above unionizing. And I just think that this is a moment right now where we have to think a bit about that. And you're seeing a lot of movement among House officers and House staff at particular institutions, but it hasn't coalesced quite yet. And I think it's one of the most powerful things that we could do. Just to echo the points that were made about inequity, I just want us to understand that in the nature of the American healthcare system, we'll never allow healthcare to fundamentally solve the inequities that exist in our society. It just will not happen because too often the nature of our healthcare system is to gatekeep against the very patients who need our services the most. And it doesn't happen at the physician level. Instead, it happens at the bureaucratic level when you say, I can't even afford that level of care. So let me self-censor, self-select myself out of getting the healthcare that I need because I worry about affording it. And so unless and until we address the lack of fundamental equality, not even equity, equality at the health insurance level, and so long as we continue to have this multiple tiered system where some people are excised entirely and many other people get treated as second-class citizens, our healthcare system cannot actually be a source of solving the fundamental inequities that we have. And the sad truth of that is that so many of us got into healthcare, got into medicine because we wanted to care for those particular patients, and we do. But at a population level, in terms of taking on those population level differences, our healthcare system is too often part of the problem rather than part of the solution.
So I throw this question out to anyone in the group, but why are doctors getting involved with DCEs and ACOs in the REACH program? Is it that they have to because they're part of a group, or why don't they leave? And, why is it that doctors are tolerating this?
Well, I think something that Abdul said earlier is part of the answer. If you think you can, as an individual, go against the whole system in a successful way, I think that's a mistake. I think you only get strength by joining together. Not only do the physicians need to form unions, and I'm so glad that most of my career has been in the public sector, where our house staff and attendings were in active and militant unions. Not only do physicians have to join together and fight for better working conditions and better situations for our patients, but it also means, excuse me, that we have to join with other people that are not physicians, other healthcare workers, and other organizations in general in our society that are fighting to change the underlying structural conditions that allow people to stay healthy, to become healthy and stay healthy. So individual, we have plenty of physicians that sort of, I don't want to characterize it too emotionally, that join the corporate interest and function as members of the corporation and think that their interest as a physician is the same as the corporation, and they go work for the corporations and make profits. So we have enough physicians that do that. There are many people that do that. And secondly, I think that how we talk, we don't actually explain to medical students or residents very well how the medical care system works in this country, much less how it works in other countries. And so physicians often get individually frustrated and confused about what's going on, and it becomes even more difficult for them individually to make some of these decisions. Most physicians, as I think someone mentioned earlier, are no longer certainly in solo practices. We're never going to see that again. And in fact, most physician practices are not even really controlled by that group of physicians any longer. They're controlled by other entities. And so that means we have to educate ourselves and join together with other people, especially non-healthcare people. Healthcare people, but especially non-healthcare people, in order to make the changes we really need to make in this country to have a good medical care system, a good public health system, and a good society.
Excellent. I mean, we tend to function as if we're in a vacuum and that we shouldn't be parts of something bigger. especially as a physician, you've sort of been raised as a physician that you're at the top of the totem pole or something, and that you're not working with others who are, helping to get to the same point with people, with patients as you, takes more than just one person, more than just yourself. And that's kind of been lost. And I don't know if part of that is because of the for-profit nature of the system that we have now.
Well, we have a psychiatrist on our panel. I would suggest there's a psychiatric problem. No practicing physician, and that was always the best part of my job. No practicing physician can honestly think today that we single-handedly determine anything. You can't run an office. You can't run an outpatient setting. You certainly can't function in a hospital without so many other well-trained, highly trained health professionals and critical essential workers that we need to make all of these systems run. So for any physician to believe that old myth that we're in charge of everything, I feel like they should go back and repeat their residency, because they should have learned in their residency that wasn't true. And it shouldn't be true, to be honest with you. So I think the first problem we have is we don't, as a collective body, we don't really pay attention to how the medical system works and doesn't work. More importantly, as Abdul has been saying, how it doesn't work. And we don't look at other countries. And so we're really at a loss to have a rational, we don't have to all agree, but to even have a rational discussion and debate about how we should structure the medical care system and how it's financed. So, but I do think this is slowly changing. More and more physicians are coming on board with single payer. I had the privilege of practicing in Canada for a number of years, and there was really no debate among the physicians in Manitoba, where I practiced, that they did not want to move and devolve into an American medical care system. They liked their Medicare system that they had in Canada. And they were clear about that. And that's not something that's very clear or as clear as it needs to be in the United States.
So as I listen to you, Linda, I guess what comes to mind for me is that we need to develop a physician organizer's handbook, because I think about the physicians where I am, and a lot of them are disgruntled and dissatisfied and feel like things aren't working, feel like there's deep interference in their patient relationship with patients, but they don't have the perspective. They've to some degree bought the idea of value-based. They've bought the idea of you have to have profit. I hear people talk about private public partnership, all that stuff. So I guess the question is, how we, and there's some people we're not going to convince, but how do we help radicalize more physicians? I agree with you. The younger physicians, it's been my experience, they are more radicalized, but can we bring some of the not so young physicians along? We're not going to do it through our medical societies. I can see that. My local NMA chapter is bought and sold by who finances them? The major insurance companies give them all their money. But I guess the question are, what are some strategies to help physicians be more aware, and also to connect more with patients, with other healthcare professionals, and so on.
I want to bring in one more piece here, which I think is important to consider. The average medical student debt, generally the student loan crisis has blown up over the past 10 years, and it has hit physicians hardest. I wrote a paper back in 2012 with some colleagues. We called it The Color of Debt, and that hits Black and Latino medical graduates the hardest. And so you end up having these graduating clinicians who are graduating with hundreds of thousands of dollars in student loan debt. They're looking at their opportunities, and they're walking into residencies or walking out of residencies where they've just dealt with an increasingly complex, as we talked about, algorithm-driven healthcare system. A lot of the humanity's been sucked out. And so I really think that as we think about where it goes, I think it is important to bring along more senior physicians, certainly, but it's also important just to, to push the younger folks along into thinking about what other professionals in similar, in industries that have been similarly pressed by large corporate interests have done. And I think even if it's not directly unionizing as more senior attendings, but also saying, listen, as you think about where you go, the fact that you're being squeezed out of the potential for, owning your own practice at all, that you're going to end up working for a large, probably multi-hospital system, ask yourself what you deserve and what it means to be able to come together with your colleagues. And then certainly if you are in a local hospital and you can help to unionize the house staff, that's a really big deal, right? And oftentimes the unionized house staff are seen as a nuisance by senior physicians and attendings. But if you can be one of those attendings who says, actually, you're doing the right thing to hold this hospital accountable, I think you go really, really far. So even if we don't get there on more senior folks, recognizing just the fundamental difference of the experience of younger folks is really quite helpful. And then helping them along to build for that future, I think is really important too.
Yeah.
I do want to just interrupt for just a couple of seconds here because I really like this discussion that's going on. And but I do want to, the staff is going to put some links in the chat because I want to make sure everybody is aware of some action items that they can get involved in and some more links to more information. But there will be some links about how to learn more information about the REACH and the ACO REACH program, and also more information about the National Single Payer Organization and also PNHP itself. There's the websites, the links to those websites will be in the chat. There's also a petition that is out that is to sign that will be urging Biden to issue an executive order ending the DCE ACO REACH program. And that link will also be in the chat. And that is telling him to stop the privatization of Medicare through these programs. Next week, there will be a call-in to the White House. It's a national call-in week for action, and that'll be on May 10th, the 11th, and 12th from 11 to 3 during the day. And the links and the numbers for those phone calls will also be in the chat, so check that. On Thursday, there is Senator Sanders is presenting his Medicare for All bill, which still is lacking some of the things that we think should be in there to actually achieve a fair and equitable and complete single payer system. But there is a Senate hearing on that on May 12th. It starts at 11 o'clock Eastern time, and the link is in the chat. Dr. Gaffney, who was the immediate past president of PNHP, will be testifying during that hearing. And then not next, but on May 23rd at 1 o'clock Eastern time, there is a National REACH campaign event, and it'll be featuring Representatives Jayapal, Porter, Pocan, and some senior and community physician leaders on that campaign event. So that link to that will also be in the chat. So feel free to access those. And I really want to encourage everybody to do this White House call. Pick a day that works for you, or call all 3 days if that works, and go to the links to get more information so that you know how to answer the questions that people come up with, and so that you can, better explain to friends and colleagues and family who have no clue that this is going on. And one of the things that, we're fighting against are all the advertisements with Joe Namath and, all of that, and trying to encourage you to get into these privatized programs, which actually we know are not better.
Yeah, I would say I would encourage everybody to decide to pledge to oneself that you will tell at least 2 other people about signing the petition, making the phone calls to make this happen. And hopefully you'll tell as many people as possible and use those resources that Susan was talking about. You don't have to be a physician to do this. In fact, we need everybody. I've already told all my family.
I love you, Emily.
I've already told all my family members, you know, send that petition, sign that petition, you know, make those phone calls. We need to jam up the lines. We need to make it clear that there are lots of people that want Biden to stop this privatization and stop it now. That it is not in the interest of the health of America. It is only in the interest of leeches, really, leeching off our public dollars to make themselves richer.
Yeah, and I think we're often
Love
surprised.
is always good, Brother Abdul. Don't be embarrassed.
I had thought I mismanaged my mute, and my daughter was yelling down at me, "I love you," and I had to reciprocate. So apologies for everyone.
Okay.
That was perfect.
Okay.
That was perfect.
You know, I hope, you know, when the draft Supreme Court decision was leaked, not that it was a surprise. You know, when I started college, abortion was illegal in most places in the country. Certainly if you were poor or Black or brown. We fought for that and we lost it. And there's a lot of things in the press. This is part of American history. We make progress and then it gets retracted. We emancipated chattel, we ended chattel slavery, and then we reinstituted it. Okay, you know, those Civil War amendments theoretically gave Black men the right to vote, but it was stripped from us. The things that we won in the 60s, like Medicare, is in danger of being stripped. That's what's going on here. We need to be clear. Just like the voting rights that we won in the mid 60s, we've lost already. We've moved backwards from those court decisions. The Medicare was a fight. It didn't just happen out of some grace. It was a fight over decades. And it happened in the mid 60s as part of the other major changes that happened there. And we're about to lose that. I sit here and watch something that I never thought in my young days would happen. I see my grandchildren who are in their 20s fighting the same exact battles that I fought when I was in my 20s against police murder, against homelessness, all these same issues. Those of us who are on this webinar, I don't care what your profession is, I don't care what your job is. If you're not angry, something you need to go see Dr. Cohen and get some psychiatric help. People should be furious. We should be furious at President Biden for not immediately canceling this Trump program, except that there is a certain part of the Democratic Party that agrees with this nonsense about privatizing is good. And so if we don't speak up and if we don't make clear what we care about and what we think is important, then our grandchildren really are going to be fighting exactly the same thing over again that we fought for.
You know, I think it's important too to acknowledge that what is driving our fight for equitable healthcare is affected by the same forces that every other social activism group is addressing for their own particular, whatever they're particularly focused on, whether it's housing, whether it's on education, whatever. It's all, the causes are all coming from the same place. And so working with other groups can only help because it's a big monster out there that needs to be slain. I
really appreciate just the opportunity to learn from each of you and appreciate your wisdom and your appreciation of the wide sweep of history. I've graduated med school in 2014, and even the degree to which a lot of the future that we hoped to build then feels very much in flux now. I mean, I remember a case on gas gangrene of the uterus that I remember learning about in med school, and there are always those pictures that stay with you, and that was one of them. And I was just reflecting on the fact that was very, very rare after 1973. And unfortunately now we're going to be seeing a lot more of it. The thing I hope that folks appreciate and understand from this particular moment is that the choices that we make today are about the fights I hope my grandkids, and I just yelled like good night to my 4-year-old daughter, but the fights that I hope that my grandkids don't have to keep fighting. And the truth of it is that it's not just that we are seesawing back and forth, it's that the baseline is getting so much worse. I mean, when we talked about health insurance, even in the Obama era, back in 2008, 2009, when the ACA was being debated, we were talking about, frankly, how do you provide health coverage for low-income people? Because by that point, out-of-pocket costs hadn't blown up so high that the nature of insurance itself was that it was unsure, right? You look at how high deductible is. The median family earns about $70,000 a year. Their deductible is about $3,600. That's a biweekly paycheck. They basically go without a paycheck just to get the healthcare they already paid for. I talk to my students about this, and I always say, look, imagine you paid for Netflix every month, and then you had to pay $19.99 to watch the movie you wanted to watch. Right? They always look at this and be like, that sounds crazy. Why would I do that? I'm like, yes, exactly. But that's how we do healthcare, right? And so it's getting worse for the median American. And so I always want us to remember that, you know, they say in politics, always be campaigning. And for us, I think we should have to always be campaigning and remembering that if we're not growing our base, if we're not building and asking, how can I recruit that next generation, that next person into my movement, and what are they focused on? I think we're missing on an opportunity. And right now, the baseline truth of the experience of patients and providers is so poor that our movement ought to be so much bigger than it is right now. And this is a moment for growth, for building, and for solving those problems that are coming around the pike. And I just deeply appreciate all the work that everyone on this panel has done. Your leadership, Susan, and grateful to just be included among you guys.
I was curious, Susan. I keep seeing flashes that there's lots of questions. I know there's 99 questions in the Q&A. Is there any pattern or any particular question that you think that we should hear and try to answer from the audience? I know you can't get all 99. Is there one or one group that seems to be?
Well, I know we have a time issue. Some of them have been addressed, but with there are 185 questions in the Q&A section at this point in time. But people are asking for advice on what they can do. I think Susan outlined that. So, yeah.
Yeah, well, I'm glad it brought up a lot of questions because it means that there's a lot that we need to learn and a lot that we still have to do. And, you know, I really encourage again to take a look at the links that are in the chat so you can get more information. You can see how you can get involved, you know, connect with PNHP or National Single Payer. And you can, if you want to be more on the front lines, and choose what you like to do. I think with any sort of social activism, you have to get involved doing something you like, because it should be something you do with passion. It can't be work that you don't like to do. And if you do it with passion, you'll do it. And you'll get to the point where you want to be with it. And I think that's the key to how you choose where you want to go with the information that you get. And we are running pretty much out of time, but I want to just thank my panelists here. I think that this was a phenomenal program, and I thank you, all of you, so much for your contributions and willing to take the time to join us tonight. And Abdul, I hope your daughter is in the bed and sleeping. But that was great. Thank you for sharing her with us tonight. But
and I've really enjoyed, I've always enjoyed listening to you, Abdul. I've enjoyed chatting with you tonight. I've learned a lot from you, and Linda a lot from you. And I hope we can get together sometime and in person, maybe.
Amazing.
The annual meeting in Boston in November. We can do that then. Okay. All right. Okay, thanks everyone for joining the call and for all your questions and comments. And thank you so much. And everyone, stay healthy.